Hello, everybody. Nice for some of you to join us today on World Arthritis Day. My name is Dr. Kai Hermann. I'm a radiologist from Berlin, Germany, and I had this idea on the last minute to start this live stream today on the occasion of World Arthritis Day to educate about imaging of arthritis. And I asked some friends if they would be willing to join. And as you see already, Dr. Sergio Viana was so kind to spend some minutes. He's from Brasilia, Brazil, and he is a dear friend, and we share similar CVs. And he has the advantage to have written a book already over me, but otherwise he's very experienced with arthritis imaging. So I'm happy that he's here today. We will discuss a bunch of cases. So as you see, we have prepared quite some. And here you can see a brief outline on what we have prepared. You will be able to try it yourself. But for now, I just wanted to welcome everybody. Maybe if you're in the chat in the different platforms, you can comment from which country you are joining today. And so we will stream this currently on LinkedIn and on YouTube and also on Facebook, but not on Instagram, as it is a different format there on the vertical layout. So we have planned to give some introduction on how to do proper imaging of the hands and feet and what you can see. And Sergio has a surprise case for us before he has to leave due to time restrictions. Okay, so we already have Asif here, who's joining from Germany, and we also have Hosan here, who's commenting in Germany when it's starting. So we did start a bit late, but we had to bring Sergio here with his video and voice. So that's what you can. And we also have Lone from Denmark. Very nice to have you here today. And as you see, she's joining from LinkedIn. So very nice that we can do that. So today we have quite some time. We have some plans. So we have an interactive case viewing platform that is called BerlinCaseViewer. I think you know it by now. You can access the platform with the short URL bcv.app/VAD24, World Arthritis D24. So you can do that. We even have a QR code that you can use, so you can scan this QR code. So if you are in front of your computer, you can scan the QR code with your mobile phone to go through the cases on your phone. And if you just watch, that's okay, because that will be like a teaching session today. So there will be only short time for you to try to try the cases yourself. So I would suggest we start right now. I will present the first case and present some principles on arthritis imaging, and then we will be curious to learn what Sergio has prepared, and also maybe curious to know the difference between X-ray technique in Germany and in Brazil. So here we have our first case. She presents with unspecific arthralgia. You see here it's a female avatar, so you know already it's a woman. When you open the info box, you can see it's a 38-year-old woman. She has slight tenderness on palpation at her joints, but no swelling of the joint. So that's always important if there's swelling or not. So tenderness, arthralgia, that's something that the patient reports. Tenderness you can feel when you press on the joints, but swelling is really something that is a more severe sign of arthritis. So you should search if swelling is taking place. So what we see here now is our set of X-ray images. So we are performing both hands separately. I know that this is not done in all parts of the world like this. because it takes a longer time than to do both hands in one shot with a larger field of view, larger film, larger detector. But if you look here, if you have one hand in the focus, that means you have the central beam coming. Give me 1 second, because I recently um, I recently told you to include, to enlarge the pointer, so I did it now. So we have this X-ray, and you see the central beam is in the center of the third MCP joint. So that is the area that is that has the best geometric qualities, because there's no distortion. Here at the edges of the film, due to the ray appearance of the beam, you might have some slight deviations of the geometry of the joints. And if you have both joints imaged together, then of course your central ray is somewhere in the middle, in between the thumbs. So the air between the thumbs is imaged the best, and the small finger is on the very lateral side. So this is not what we recommend. And also what we are doing is we are doing an oblique view, which is kind of a second plane. And depending on the country you are in, we have different names for these views. So in Germany, we call it the zither player position, because in Germany, in some areas, we have the zither is like a guitar laying on the table, and you do it with your hands. But it's also like if you catch a ball. The ball catcher position is also called, or some things. It's I think Lone will say that it is called the Norgard position, because in the Scandinavian countries, Dr. Norgard was very advocate about this. Okay, and here we see the oblique view of the joints. So you do not do a true lateral view, because then you do not see the joints. Okay, and if we go and search for the findings, of course, we are trying to evaluate the joint spaces. We evaluate the bones, also the mineral density. The cortex is important if there's demineralization. Also, it should be coming directly to the joint, the spongious bone, and in some form of arthritis, this very nice spongious cancellous bone here is going away. Then we call it demineralization. And if it's very pronounced next to the joint, we call it periarticular demineralization, and it gives us a sign of early arthritis. Then also we need to take care of the wrist bones. So there are 8 bones here. The pisiform, the equitrum, they are difficult to take apart. Then we have the lunate, the scaphoid. Then we have the hamate, the capitate, the trapezium, and the trapezoid. And these 8 bones should be visible with a clear joint space in between, about 2 millimeters or 1 millimeter of width. And this joint clefts should be uniform across all joints. Also, the radiocarpal joints should have the similar width as these joints here, the intercarpal joint. And then also we have another joint here, which is the joint between the distal ulna and the distal radius. It's called the distal radio-ulnar joint. And this is, in fact, a separate joint. It's not part of the wrist joint or the radiocarpal joint. So this is a separate joint, and this is very important. Okay, so that is what you do, and here on the oblique views, you can see that here you have now a better delineation of the joint contours. You have a second plane. You also see the sesamoids of the fifth and the second ray, and also of the thumb. You can see them also here, but it's overlaying the normal bone on an AP view. So you can maybe comment who is doing obliques in which countries. Lone even gave us the correct spelling of Norgard, and so you can take this away right now. So if you are in a radiological department elsewhere, just say if you do one planes or 2 planes of the hands. In fact, the second plane is disappearing slowly. Also, we are sometimes doing it only in one plane due to time constrictions. Sometimes it is not feasible to do two planes all time. Okay, so this is the introduction for the first case, and I'm going back to the overview, and I will ask Sergio if you do two planes or one planes in your institution.
Two planes. It's a routine in my institution and in Brazil overall.
That's very good to hear. Very nice, very nice. Okay, so do you do both hands separately, or what do you get?
Uh, it actually it differs a little bit among institutions. When both hands or both wrists are required, sometimes we do both at the same time, and sometimes separately. It varies a little bit. There is not a strict routine to adhere.
Okay, okay, cool. Okay, so yeah, I showed a little bit on the normal anatomy. Sergio, do you have a difficult case or an easy case? Should we show some normal, like typical type of arthritis before you challenge me, or what do you want?
No, it's not a difficult case. It's not a special case. It's a very typical case, but it's a case with advanced features. So I think it would be better for you to show your case first, and then I'll show mine. What you think?
Okay, okay. So I will show one not so advanced case, maybe yeah,
Okay.
not so advanced before, and this will be a challenging situation for many of you if you see that. So if you want to join on your device, or if you want to look independently on the case, you can do that. Even there are two questions here that that you can answer, please, so that we know a bit about your knowledge. And also, I wanted to share some fun function that we have. So if we go here to the first case, there is no question for you provided, but you can ask us a question. So you can click here on the speech bubble with the pin. That's our pin and comment feature. If you click it, you get this pin in the center of the image. Then you can move the pin around the image. So you could actually place it here and confirm the position. And then you can ask, what is that? And this question will be then submitted to us, and we can answer it. It will appear in our question answer panel, as you see here, and we can answer it right now in the live stream, but also after the event, days later, we are able to answer it. So that is something that I would encourage you to try. Okay, let's go to our second case. And here we see this is a man, this is a 48-year-old man with swelling and pain in the finger joints and also in the wrist on the left side. And there are complaints that have been present for about 3 years. And on investigation, there's some pressure pain and swelling at the second PRP joint and also on the third PRP joint on the other hand. And there's positive evidence of rheumatoid factor, and CRP is elevated. So when you look at this image, so of course you need to know how the normal hand looks like. So it's very difficult to see the changes here if you are not, let's say you have not seen 200 or 300 hand X-rays already. So what's always advisable is to have these two hands next to each other. So if you have the two hands next to each other, then it's maybe a little bit easier, although this is still a difficult case. So I would recommend to go through this these X-rays in a joint region fashion. So that means you start with the DIP joints and look at the DIP joints and compare them. As a fun or not fun fact, as a fact, the interphalangeal joint of the thumb is regarded the DIP joint of the thumb. So the thumb has, in fact, no PIP joint because, for instance, in psoriatic arthritis, these joints, they behave like a DIP joint also because they are close to the nail bed where we have sometimes overlapping features in psoriatic arthritis. So the DIP joints look very good. And this is also typical for rheumatoid arthritis because the rheumatoid arthritis does not affect the DIP joint, the distal interphalangeal joint. So that is just a fact. So it's really difficult to understand, but this is how it is. So then we have the PIP joints. And here we see already there's some soft tissue swelling in some of the joints. We know already in the medical history, there was some soft tissue swelling reported and also some tenderness of the joints. And you need to distinguish the soft tissue swelling that is fusiform around the joint, like here, and you need to distinguish it from the knuckles that we sometimes see. So if you look here, we have this bright area here, and this is not a swelling inside the soft tissue. So this is the contour of the hand. And if you would have a photo of the hand, you would see this is the knuckles, the prominent knuckles that are sometimes showing off. So that needs to be taken care of. But here we have a toe swelling. And the next is we compare the, also enlarge this a bit, we compare the MCP joints. So that's the next step. I need to readjust the MCP joints. And when you compare the MCP joints, you see already some swelling here in the left side, but you see the difference between the left side and the right side. In the right side, you can see there is this defect here, which is not here. And also you can see that's the normal contour of the metacarpal bone, and there's some very shallow defect over here. Then we see the cyst-like change. So there are already two joints that are looking very suspicious. We have the fourth and the fifth joint, they look good. And if we go to this side, we see also the second, third, and fourth MCP joint look good. But here on the fifth joint, maybe there's a cyst. And then when we do not forget the thumb, we can see that the thumb is already destroyed. We have some smaller cystic changes here in the MCP joint of the thumb, but we have larger destruction in the right side with large lucency over here and over there. So these are some larger erosions. And when we then go to the wrist and compare, then so we saw more erosive destruction here on the right side. So here we see now the carpal bones on the right side look very good, but on the left side we see defects over here. It looks like an osteolysis. We see it here. We see a little bit of widening of this joint, which is a sign for destruction of the scapholunate ligament. There's some lucency over here and even in the radius. And though this is a case of rheumatoid arthritis, which is when we don't have a magnification, looks almost normal. And the question was here, which joints were and of course you did not have the time. Okay, so when I answer it, I would say the MCP joints, CMC joints, intercarpal joints, and the radiocarpal joints are affected because we had this erosion MCP joints. We had the CMC joints affected, the intercarpal joints, the radiocarpal joints. So this is my answer. And when you answer it, of course, you can get the BerlinCaseViewer explanations that we made available inside the image, so you can learn in the image and you can see these erosions all explained. Next, we look at the feet. And at the feet, of course, you check for soft tissue swelling, you check for erosions, especially at the MTP joints, metatarsophalangeal joints, and take special attention for the fifth toe. And here the fifth toe on the left looks good, but the fifth toe on the right, there might be some change over here. Also here we see some lucency, and here we also see a little bit of change. So that is what we have, and at the end of the case we even explain what we can see, but I think I explained already what this case is about. So this is a patient with erosive rheumatoid arthritis. So you can comment how you would have solved this, and I get this nice comment here, I think Imane from France. Thank you for joining, and thank you for taking part in the chat. So any questions regarding the cases, do it, present it. If you use pin and comment, I will also take a special note if there are something coming in. And Sergio, now I think it's time for your advanced case to get us challenged a bit. And so we need to set up your screen share. And so there's the share screen button or present button at the lower end of the screen. And then you can share your entire screen or just the window with the PowerPoint. Is it working?
Just a second.
Yes, yes, yes.
Okay. I think
Meanwhile,
it's
we have coming. Meanwhile, we have new viewers. So if you are commenting from where you are, that would be nice. We have nice French comments here, and I'm really happy to see all that. Sergio, is it so? There is the button is called present. Do you see it in the studio, in the live studio, or below our video? There is the button present.
Yes, I can see, but there is an issue with the browser with Chrome. It's the first time I use this platform.
It's asking, so you can switch. You can
what should I share? What should I share? The Chrome tab, the window, or the full screen?
The window. You should share the window, and then select the presentation window.
Well, something's not right here.
Then you can share the entire screen. If you share the entire screen, but then you maybe need permission and need to quit Chrome before.
I think I'll have to restart Chrome.
Yes.
Maybe it's better for you.
I do the next case, and you try to go in again. Okay.
Yeah, okay.
Nice. Okay, so we will continue, and I will present. The next. I will present the next case, and we wait till Sergio is back. And here we have a very nice and interesting case. And here, this is a case, psoriasis and joint complaints for 20 years. So if there's a patient with psoriasis, that means there are some skin lesions. And as you know, there are so in our region, in Central Europe, about 10% of the population is said to suffer from psoriasis. And 10% of these patients are at risk to get psoriatic arthritis. That means 1% of the population, in fact, may have psoriatic arthritis sooner or later, which is as frequently as rheumatoid arthritis. And therefore, if you have a history of psoriasis and you get X-rays, you should search for psoriatic arthritis. Not all patients with psoriasis and joint pain have at the end psoriatic arthritis, because as they get older, also osteoarthritis of the DIP or PIP joint occurs. And then it's very difficult to distinguish osteoarthritis from psoriatic arthritis. There are some hints what you can do, but it's not always easy. So here we go to our case, and you see that this is a patient, 56-year-old, long-term psoriatic patient and also pain in the fingers and wrists. So it's quite convincing. Elevated CRP, but usually these patients do not have rheumatoid factors or ACPA antibodies. And peripheral psoriatic arthritis is also not so much connected to HLE-B27. So there is no real lab test that can help you, as far as I know. And again, if you compare the two X-rays here, I hope you see already the extreme changes that this patient is exhibiting. We go back to the single view so I can enlarge more. So if we start at the DIP joints, we see that these joints, there are no joint spaces visible. Maybe this is a normal joint space. So this space, this gap between the bones should be also visible here and there. And you see there are these outgrowths of the bone over here at the edge of the joint, also here. So these are called periosteal proliferations or periosteal spikes. And this is a new bone formation that is caused by the psoriatic arthritis. Also here we see the psoriatic bony outgrowth at the DIP joint, and also you see that the nail, the tuft here, is a little bit looking strange. So maybe there's also some periosteal proliferation at the distal tip of the fingers, and these are usually connected also with psoriatic nail changes. Then when we go to the PIP joints, they look quite good, except this one here on the second ray, where we see also some joint space narrowing. And here the thumb has very severe periosteal reaction, very large, kind of osteophytes. So you can mistake these changes for osteophytes. But if it is ill-defined, then you should think about periosteal proliferations. Even here you see there is some shallow ossification. And in addition, there's also an erosion, like in our second case. This is an erosion. So this psoriatic arthritis leads to new bone formation, but also leads to erosions. And here we see the other side where we can see there's an erosion here at the thumb. There is even ankylosis here, so that is an advanced stage of psoriatic arthritis. We have some smaller periosteal changes over here, and there's also ankylosis over here. And when I go for which of the following findings can be seen, so it's according to both X-rays. So I will show both X-rays here, and then I will call the question. And so periosteal proliferations in the distal phalanges, okay, I would say yes. In the PIP joints, yeah, not sure. There was one joint, but it was very minor. MCP joints, definitely. Carpal bones, definitely. And there's erosions, yes, and also ankylosis. So that is how I would do it. Maybe I would neglect this one PIP joint. So let's see what I did. So I made this question many years ago, but still I remember. So I'm curious if, one, maybe Lone or whoever, or Imane answered. So let's see what, it's stupid. I was doing it myself. Okay, so this is too late today to do this kind of stuff. And then we look at the feet. And at the feet, we can see there's ankylosis here. And there's another finding. So you need to know when you search for arthritis, there are different types of findings that you can see. There is very early signs. This is soft tissue swelling and periarticular demineralization. They are very unspecific. Then we have the mid-range changes. These are erosions that show the destruction and also maybe periosteal proliferations. And then end-stage arthritis, you have two types of changes. You can have ankylosis if the joints are fusing, and you can have mutilation. That means the joint is no longer there and it's completely gone, and that is called a mutilation. So in our case, we have here both. So we see that we have many joints fused, they are ankylosed, and we have here the joint is gone. So this is the opposite of the ankylosis, so this is the mutilation. And So that is about this case. So I already I see the pain in many of you, and I know arthritis imaging is nothing fun for radiologists, and I'm really happy about these nice comments. Okay, so this is a case of severe psoriatic arthritis, and of course I'm now curious if Sergio has done the similar case or not. And let's try to share the screen.
I think it's all set up here now. Just a second.
That would be wonderful.
Well, let's try it.
Yes, it's there. Wonderful. Nice.
Can you see it
Nice.
in the full screen?
It is already nice. I see the full screen.
Okay. Uh, well, first of all, I would like to thank Kai for the this kind of invitation. It's quite a pleasure for me to be here, and it's always a pleasure for me when he compares his curriculum to mine. Of course, he's a world-class scientist, and it's always a pleasure for me as a simple radiologist from Brazil to be invited to be part of a discussion like this. Well, but this is a case of a 15-year-old girl with long-standing arthritis. This is a set of radiographs of the hands and wrists, and there is evidence of chronic arthritis of the wrist, of the carpal metacarpal, and of the metacarpal phalangeal joints with diffuse osteopenia, which is due to the underlying chronic hyperemic process, diffuse joint space narrowing with near total carpal ankylosis on the left, and boutonniere deformity of the proximal interphalangeal joint of the right foredigit. In addition, there is bilateral early and asymmetric closure of the distal physis of the radius and ulna with bilateral ulnar shortening. And this is a very peculiar finding. Note the radial cortical remodeling adjacent to the distal ends of the uvulae due to shortening and convergence of the latter and associated ulnar impingement. This case is quite appropriate for demonstrating multiple complications related to the subjacent disease, which is juvenile idiopathic arthritis on X-rays. For advanced changes, X-rays are very appropriate for showing this kind of abnormalities. And this is it. I think there's nothing special about it, but it's a quite illustrative case to show advanced findings in juvenile idiopathic arthritis.
It's really advanced, and in fact, these cases are scaring me because I have no access to juvenile arthritis cases in my daily routine. And I learned at least that the shortening of the ulna is a typical sign for juvenile arthritis. So that is good to know. And also these demineralizations are quite extensive. So the joints. Do you think this all happened when? So how old is the patient here at this point when the X-ray were taken?
Sorry, I didn't get it.
How old is the patient now when the X-rays were done?
How old?
Yes.
Uh, Sorry, once again, I
Of the
didn't get
age,
it.
the age of this patient?
15. It's a girl, a 15-year-old girl.
Okay, okay. And arthritis is going on
I don't know
10 years?
exactly, but not less than a decade, for sure.
Less than a decade. Also less than 10 years. Okay,
Yes,
okay,
yes.
okay.
On my latest book, there is a case in which the findings advanced from an advanced case to a total ankylosis of carpal ankylosis in 6 months in a non-responsive case, in a non-responsive patient.
Okay. So I let me show. Yeah, I should.
Would you like me to stop sharing the screen?
You can keep the screen shared, so that's no problem. I will also share something.
Okay.
I will share. I will share. Hold on. Because you just mentioned it, I thought it would be fair to tell everybody that you wrote a wonderful book that came out just some weeks ago, and it's in Portuguese. So I think most of the people who are in the live stream right now, they will have not so much benefit of it, but maybe those who watch the recording later will consider your book. Okay, Sergio, it was very nice seeing your case, and it's really great how it works over the continents, the different time zones, and so everybody, you should need to know that only 5 hours ago I asked Sergio to be my guest, and he was so kind to accept, although there's a public holiday today in Brazil. So Sergio, it was very nice to have you. And I will continue for the next 15 minutes or 20 to show some more cases. If you stay here, we will see something very rare. Maybe I do it the next, immediately the next case. So I will share my other screen again. And I'm curious if Sergio has seen such a case in his life. So
let's see it.
We have this case number 8. And we have this case number 8. And this case is a woman, a 46-year-old woman with progressive arthritis of both hands. And she had also Raynaud's phenomenon. And as a special clinical finding, she had multiple skin lesions, like small papules at the skin, at the nose, at the ears, also at the fingers. And the dermatologist took out one of the skin lesions, and it was with giant cells. So here, you see this is a rather old case. It's really rare, and I got it from my former mentor. And when you look at these X-rays, you see that there are symmetric changes in this patient, and these symmetric changes, they affect the DIP joints. There's mutilation here at the DIP joint, there's erosion at the DIP joint, and similarly on the other side. Here, mutilation, here's an erosion, here's an erosion. And there is also a little bit of pathologic change in the PIP. It's maybe not so pronounced, but here you can see also an erosion. And there's some cystic change here in the MCP joint, and lower down here in the wrist, there's no change, but maybe there's a change over here. We have DIP and PIP involvement. And so here we could think about some psoriatic arthritis, because there's also this periosteal spike here in the area. But psoriatic arthritis does not show papules of the skin, and also no giant cells, I guess. So then 5 years later, patient came again. And now we have even more severe changes. So we see there is now mutilation of even more joints. We have mutilation over here with this one single joint still intact, but the other joints are gone. And we have now also erosions here in some of the MCP joints. So the question is, what could it be? And there are 6 options that we could think of. Psoriatic arthritis, I already explained, could be because of the DIP joints. Then pustulosis palmoplantaris is related to the SAPHO syndrome, which is now called the CNO syndrome, chronic non-bacterial osteomyelitis. So that's related to psoriatic arthritis, although it's a different entity. Then we can have like neurofibromatosis, where we have maybe bony relation, then there's a disease called multicentric reticulohistiocytosis. Then rheumatoid arthritis, I think, is not relevant because it would not affect the DRP joints and something completely different. And in fact, the correct answer, oh, somebody did answer. I wish I would know who it was. So that's the correct answer. Multicentric reticulohistiocytosis is the correct answer. So this is a skin and bone disease. That's a disease that affects the skins and the synovial lining in the joint reacts like a skin in this type of disease. And so these papules, they are not only coming out of the skin to the outside, they are also inside the joint, and they are in the synovial membrane, and they lead to pressure defects in the joint. So that's not a synovitis in the joint, but it's these small bulges coming out of the synovial membrane. They press on the bone for a long time and destroy the bone slowly, and the bone is going away, taking away. And I thought it's so rare, I should use the occasion today to show this. So Sergio, do you have such a case in your collection?
Not in this life.
Not in this life.
No, never.
Okay. So it's also
first time ever.
It's also called so because these are histiocytes. So these are histiocytes in this history. Maybe I make a video about it with some proper PowerPoint and presentation to know about it, as I see that there's never heard about it. And also, Sergio, you see somebody called you a good teacher, as you presented a very wonderful case. So that was my most rare case, and I think we have some minutes left that will lead me to show at least one more case before we go. And so we have here. This is all interesting cases. So we have here maybe this case, a woman, 55 years old, with known scleroderma, and there's also ulceration and stiffness of the fingers. And I work in a center where scleroderma is a frequent disease because we have rheumatologists who are very skilled in treating scleroderma. But scleroderma per se is a rare disease, and I think few radiologists are ever available or in the chance to see scleroderma, and therefore it's important to teach it and to show what's going on. And scleroderma is a collagen fiber disease. So that means we have collagen, so the soft tissues are inflamed, there are cellular infiltrates, and we have therefore hardening of the skin. We have vascular disease, so we have like vessels are getting narrow, so there is destruction of the bone due to low blood supply. And this is exactly what we can see here. We have atrophy of the tuft, atrophy of the distal edges of the fingers, and so that's the normal appearance of the distal phalangeal joint, distal phalanx. So it's getting atrophy. The soft tissues are still there, but sometimes you see the bone is going halfway gone, and then also the finger gets shorter. Most usually it's the appearance of the distal joint. Here you see a little bit of calcification that could be due to scleroderma, but could also be to vessels maybe. And then if you look at the other side, you see that here we see also this atrophy of the bones, and we see these typical calcifications. So calcifications all over the soft tissues are the hallmark of findings in scleroderma. Later on, patients then also cannot bend straight their fingers. They are bended, and they are, so you're getting an AP X-ray that is not AP, but that's bended, so you cannot see the joints very well. So that's a typical example of scleroderma, and you see how the disease progresses if you have this hand, and then compared to the follow-up after 5 years, you see that here new calcifications are showing up compared to here. And if you go to the other hand, we see that these calcifications, they get bigger. And otherwise, here the soft tissues, they have some changes. Sometimes really there's some even necrosis of the bone. Okay, so that's a case of acro-osteolysis and calcinosis in scleroderma. Okay, so what else can we have? We have some more comments. So we have this one of my relatives had, yeah, it's awful. It's because it's not only affecting the bones, it's also affecting the lungs. You have problems swallowing, as there is affected, and you have also Raynaud's phenomenon. You can have skin lesions, so that is really nothing. That is a nice disease. Okay, so thanks for joining us on World Arthritis Day. I think I, together with Sergio, showed you different types of arthritis, normal X-rays. I showed you the lateral view. I prepared even one case where I wanted to show the value of the second plane with an erosion showing up in the second plane, but I skipped it due to the time. And we showed we looked at psoriatic arthritis, at scleroderma, and at the rare arthritis of reticulohistiocytosis. So thanks for joining. As you know, BerlinCaseViewer cases are always well annotated, so I only recommend looking at our site. We are currently transitioning from our apps. Usually we had our apps available on mobile phones. It started with iPad, later iPhone, and also on Android. And we are now transitioning back to the web browser to have people view our cases on the large screen. That means on a PC, large screen at work, large screen. That is coming during the next day. And if you follow our social channels, you will learn about it. So thank you for taking the time, for spending this hour with us, and see you at the next occasion, and have a nice day in Brasilia, Sergio. Bye-bye.
Thank you, Kai. Bye-bye.
Bye-bye.